Inflammatory diseases of the genital organs in girls and women leading to impaired reproductive function. Etiology and transmission. Pelvic inflammatory disease is usually the result of infection ascending from the endocervix causing endometritis, salpingitis, parametritis, oophorytis, tubovarian abscess, and pelvic peritonitis. Neisseria gonorrhea and chlamydia trachomatis have been identified as a causative agent. Mycoplasma genitalium is a likely cause and anaerobes are also implicated. Microorganisms from the vagina flora, including streptococci, staphylococci, Escherichia coli, and Haemophilus influenza, can be associated with upper genital tract inflammation. Mixed infections are common: bacterial vaginosis, urogenital, candidiasis, uroplasma, mycoplasma gominis. Factors associated with PID. Factors related to sexual behavior: young age, multiple partners, recent new partner within previous 3 months, past history of sexually transmitted infection in the patient or their partner, instrumentation of the uterus, interruption of the cervical barrier, termination of pregnancy, insertion of intrauterine device within the past 6 weeks, hysterosalpinography, hysteroscopy, saline infusion sonography, and in vitro fertilization. Clinical features. Symptoms of PID may be asymptomatic or symptomatic. Even when present clinical symptoms and signs lack sensitivity and specificity, the possible predictive value of a clinical diagnosis is up to 90% compared to laparoscopic diagnosis. The following symptoms are suggestive of a diagnosis of PID. Lower abdominal pain, usually bilateral. Deep dyspareunia, particularly of recent onset. Abnormal bleeding, intermenstrual bleeding, postcoital bleeding, and menorrhagia can occur secondary to associated cervicitis and endometritis. Abnormal vaginal or cervical discharge as a result of association, cervicitis, endometritis, or bacterial vaginosis. Physical signs include lower abdominal tenderness, adnexal tenderness from bimanual vaginal examination, cervical motion tenderness from bimanual vaginal examination, fever more than 38 degrees, and pelvic tenderness. Urogenital candidiasis. Urogenital or vulvovaginal candidiasis is probably the most common condition of altered vaginal microflora that occurs in the reproductive age group. Approximately 75% of women in the reproductive age group experience this condition. Irritation, redness, edema, or external genitalia and vagina, with up to 50% of these women experience a subsequent episode and 5% involve to recurrent and chronic vulvovaginal candidiasis. Urogenital candidiasis treatment. Acute form is treated by Orungal 200 mg twice a day during 3 days. A chronic form is proposed to 100 mg twice a day during 6 or 7 days. Then during 3 or 6 days menstrual cycles, 1 capsule of the first day of menstrual cycle is taken. High effectiveness is observed while using diflucan dose 150 mg per 1 reception, in severe form 2 or 3 times per 1 week. And genopervarial one suppository 150 milligrams during 3 days in case of recurrent form, one suppository 50 milligrams twice a day for 7 days, and application of gynopleural cream on glans penis during 10 days is recommended. Prophylaxis. First, vaginal antibiotics treatment with keeping optional doses and duration of the therapy course is using antimycotic medicine with the preventive aim. Second, avoiding premarriage and extramarital relationships. Third, using condom. And fourth, reducing sweets and alcohol. Bacterial vaginosis. This is very common and occurs when lactobacilli are replaced by anaerobes, etc., Prevotella species and Mobilincus species, Gardnerella vaginalis, Ureaplasma, Mycoplasma, and numerous fastidious or uncultivated anaerobes. It is not sexually transmitted, and many women are asymptomatic, but it can cause an offensive green and gray discharge. The pH is raised up to more than 5.5, and bacterial metabolite produced volatile amines with a fishy odor, particularly after intercourse. Here you can see normal vaginal mucosa, lactobacillus are more than 95%, and bacterial vaginosis. Bacterial vaginosis treatment include metronidazole 500 mg orally twice a day for 7 days, or metronidazole gel 1 full applicator intravaginally once a day for 5 days, clindamycin cream 2%, 1 full applicator intravaginally at bedtime for 7 days. Alternative regimens include tinidazole 2 grams orally once daily for 2 days, or tinidazole 1 gram orally once daily for 5 days, or clindamycin 300 milligrams orally twice daily for 7 days, or clindamycin ovules 100 milligram intravaginally once at bedtime for 3 days. Ureaplasma and Mycoplasma infections. It has been mentioned above, Mycoplasmas and Ureaplasmas are opportunistic microbes, but earlier, 10 and 20 years ago, the microorganisms was considered to be strictly pathogenic. The most frequent opportunistic mycoplasmas is in genitourinary tract are Mycoplasma communis, Ureaplasma parvum, Ureaplasma uraliticum. In 10 to the 4th power might consider to be pathogenic. Mycoplasma. Mycoplasma communis is opportunistic microbe. Mycoplasma genitale and Mycoplasma pneumonia are pathogenic microbes. Ureaplasma divides into Ureaplasma uraliticum and Ureaplasma parvum. All of them are opportunistic microbes. And opportunistic microbes, more than 10 to the 5th power might be considered pathogenic. The pathogenic amount more than 10 to 4th or 5th power Ureaplasma parvum and Ureaplasma uraliticum may cause fetus disorders by vertically transmission, etc., bacteremia, pneumonia, chronic lung disease, and nervous system infections. If colonization occurs It can cause recurrent miscarriage, preterm labor, coronary pneumonitis, early onset sepsis, and bronchopulmonary dysplasia in baby. I mentioned about Ureaplasma species and Urealyticum and Parvum. Mycoplasma gominis had the same influence on the organism in the quantity more than 10 to the fourth power and fifth power might be considered to be pathogenic. And it is strongly associated with coronary pneumonitis, pelvic inflammatory disease, bacterial vaginosis, and in pregnancy, it may cause lower gestational age at delivery, lower birth weight, increased neonatal morbidity and mortality, increased risk of miscarriage at 14 weeks, and in infant can cause pneumonia. Mycoplasma genitalium is a pathogenic microbe. Is a causative agent of urethritis associated with cervicitis, pelvic inflammatory disease, and endometritis in women. Pregnancy is unknown. Chlamydia. Chlamydia trachomatis is one of the most common bacterial sexually transmitted organisms. During the past 20 years, the spectrum of diseases caused by Chlamydia trachomatis has expanded dramatically, and an increasing number of infections have been attributed to Chlamydia trachomatis. There are 4 recognized species within the genus Chlamydia: Chlamydia trachomatis, Chlamydia psittaci, Chlamydia pneumonia, and Chlamydia picorum. Chlamydia trachomatis is the high prevalence agent associated with wide variety of complications. The majority, up to 80% of chlamydial infections of the lower genital tract in women are asymptomatic, and it can progress to the upper genital tract to produce serious complications such as PID, chronic pelvic pain, tubal factor infertility, ectopic pregnancy. The chlamydial organism exists in 2 forms. First is elementary body, which is the infection particle and capable of entering uninfected cells. Second, the reticulate body, which multiplies by binary fission within the host cell to produce the inclusion for and are identified for properly stained cells. Epidemiology, risk factors, and pathogenesis of chlamydia. For the oculogenital serotypes, the primary method of transmission is sexual. Between 30% and 50% of women with lower genital gonorrheal infection have concomitant chlamydial infection. Reiter's syndrome is a systemic clinical syndrome associated with chlamydia infection in men. A number of clinical conditions in the female have been attributed to Chlamydia trachomatis. These include mucopurulent endocervicitis, endometritis, salpingitis, acute urethral syndrome, urethritis, and peritoneal infection. The anatomic site within the female genital tract most commonly infected with Chlamydia trachomatis in the cervix. No specific symptoms are associated with the cervical infection, and so many of the chlamydial infection of the cervix are clinically inapparent. This is unfortunate because mucopurulent cervicitis caused by Chlamydia trachomatis predisposed to acute PID in non-pregnant women. In addition, asymptomatic chlamydial cervicitis is a major reservoir for sexual transmission of Chlamydia trachomatis. The majority of women with chlamydial disease remain untreated because their infection is either asymptomatic or relatively inapparent. Untreated, the infection cause, can persist for several years and subject those infected to the risk of spread of chlamydia trachomatis up to the genital tract, with subsequent infertility and ectopic pregnancy. In addition, these women are exposed to scientifically increased risk of infertility and ectopic pregnancy. Genital complications associated with chlamydia. First, endocervicitis. An anatomic site within the female genital tract most commonly infected with chlamydia trachomatis in the cervix. Chlamydia trachomatis is a major cause of mucopurulent cervicitis. The acute urethral syndrome, urethritis, and cystitis. Endometritis. The infected cervix may range from clinically normal to severe cervix with a hypertrophic cervical erosion and mucopurulent endocervical discharge, and acute urethral syndrome, as I said, is defined as acute dysuria and frequent urination in a woman with pyuria but whose voided urine is sterile or contains less than 10 microorganisms. Endometritis is another manifestation of genital chlamydian infection. Histologic endometritis based on the presence of plasma cells and infiltration of the superficial epithelium by leukocytes has been detected in nearly one-half of patients with chlamydial mucopurulent cervicitis. The presence of histologic endometritis has been associated with both cultural and immunohistologic detection of chlamydia trachomatis. Histologic endometritis can be detected in nearly all patients with chlamydial salpingitis. The most serious complication of chlamydian infection in women is acute pelvic inflammatory disease. Chronic and subacute or latent PID is present in a large number of women. Unfortunately, unrecognized PID appears to be likely as recognized to result in progressive scarring in fallopian tubes, resulting tubifactor infertility and ectopic pregnancy. And acute perihepatitis. I will show you later. In this slide, you can see an illustrative example of chlamydia-associated complications. Cystitis and urethritis in the inflammation of mucosa of the bladder and urethra. Endometritis is the inflammation of mucosa of uterus called endometrium. And acute perihepatitis, Fitz-Hugh-Curtis syndrome, which is characterized by localized fibrinosus inflammation affecting an anterior surface of liver and the arterial peritoneum and liver. This is abdominal wall, this is liver, and here you see adhesions below liver and abdominal wall called Weill-String signs. In this slide, I'll try to show you chlamydia-associated inflammatory disease of cervix. This is healthy cervix. This is cervix infected with chlamydia. You can see cervical cream-looking sticky discharge, redness, and or ectopy of mucosa of cervix. Here you can see on the redness, and I can't see here ectopic. This is normal cervix. The slide below, pictures below demonstrate normal anatomy of female pelvic organs, left side, and right side, a pelvic adhesive disease. These are multiple planar adhesions between ovary. Here I'll try to show the ovary. It might be here, but the planar adhesions here, and you can't see the ovary. Also, you see here fimbrias are normal fimbrias, very such kind of, and here you can't see fimbrias, they are absent because of this adhesion. Here is a bowel, and this adhesion between bowel and ovary and fallopian tube. It might be here with fimbrias here. Then the treatment of chlamydia, ureaplasma, and mycoplasma infection include macrolide group, erythromycin, sumamed, rocrexamycin, tetracycline group, tetracycline, doxycycline, and fluoroquinolones, ciprofloxacin. It is etiotropy treatment. They are prescribed for not less than 10 to 14 days with the following laboratory controls: smear on flora or yearly, then 2 or 3 weeks after treatment. Another course of treatment: immunity stimulation, immunoglobulin, levamisole, T-activin, ginseng tincture, polyoxidone, prophylaxis, examination of the risk group, prostitutes, women with infertility, inflammatory process of genital organs, and keeping to the same measures for preventing sexually transmitted diseases. Gonorrhea. Common symptoms are the same with chlamydia infection, include vaginal discharge, dysuria, intermenstrual bleeding, menorrhagia, and pelvic discomfort. Up to 20% of women with uncomplicated anogenital gonorrhea occurs genital tract infection. The cervix infected with Neisseria gonorrhea can appear healthy or reveal an inflamed cervical canal with ectopy or mucopurulent exudate. The area of ectopy is edematose, erythematose, and frabel. The signs of gonococcal cervicitis are indistinguishable from other causes of cervicitis, and thus an absolute diagnosis of gonococcal cervicitis requires laboratory test confirmation. Transmission of gonorrhea is almost only by sexual contact. The female is a greater risk of infection than male. The incubation period is short, from 3 to 5 days. Neisseria gonorrhea is an important cause of urethritis, cervicitis, and pelvic inflammatory disease. Disseminated gonococcal infection manifests 2 stages: an early bacteremia stage and a late stage. The bacteremia stage is characterized by chills, fewer typical skin lesions, and asymmetric joint involvement. Blood culture are positive for Neisseria gonorrhea in half of culture during the bacteremia stage. The bacteremia stage is associated with dermatitis that is characterized by a variety of skin lesions due to gonococcal emboli and occurs up to 75% in case. These lesions appear initially in small vesicles that become pustules and develop the hemorrhagic phase. The center becomes necrotic. These lesions occur on any body region, but are most frequently present on the volar aspects of the upper extremities the hands, and the digits. These skin lesions resolve spontaneously without residual scarring. Asymmetric joints involvement is the usual person most often affected the knee, elbow, wrist, ankle, and metacarpophalangeal joints. The arthritis is migratory. The joint heals as another becomes affected. In two-thirds of patients, tenosynovitis is present. The most frequent sites are the dorsal tendon on the hand, wrist, and ankle. The late stage of disseminated gonococcal infection is characterized by frank arthritis with permanent joint damage, endocarditis, meningitis, pericarditis, osteomyelitis, and perihepatitis. With arthritis, the knees, ankles, and wrist joints are the site most commonly involved. Here you can see gonococcal arthritis, and here is the rash, gonococcal associated. Diagnosis and treatment of gonorrhea. Diagnosis include gram stain, bacterial cultures, immunochemical detection, immunoenzyme analysis of blood, molecular diagnostic techniques as PCR, polymerase chain reaction of discharge. Neisseria gonorrhea is sensitive to a large number of antimicrobial agents, including penicillins, tetracyclines, macrolides, cephalosporins, erythromycin, aminoglycoside, and quinolones. Sexual partner of patients with gonorrhea should be examined, tested, and treated. Ceftriaxone is a drug of choice for gonorrhea treatment. Patients with allergic to penicillins and cephalosporins can be treated by spectinomycin 2 grams every 12 hours. Women treated for gonorrhea should also be presumptively treated for chlamydial infection. Azithromycin 1 gram orally in a single dose, or doxycycline 100 milligram orally twice a day for 7 days. And repeat screening through 1 to 2 months after treatment. Trichomoniasis. Trichomonas vaginosis, a flagellated protozoan, is the etiologic agent of trichomoniasis. The urogenital tract is the primary site of infection, which presents with a wide spectrum of symptoms. Trichomonas vaginalis has been identified as a predisposing factor in transmission and acquisition of HIV. Its frequency rate reaches up to 70% sexually active women. According to the World Health Organization statistics, 10% of world population suffer from trichomoniasis. Non-sexual transmission is very seldom. When they use sponges, underwear, towels, incubation period is lasts up to 2 weeks, 15 days. The main place of trichomonas parasitizing are mucous membranes of vagina, cervical canal, uterus cavity, uterine tubes, Bartholin glands, duct, urethra, urinary bladder. Inflammatory process develops in the infected mucous membrane, edema, hyperemia, exudation, desquamation affect epithelial cells. Trichomoniasis clinical features include vulvovaginitis, urethritis, endocervicitis, exocervicitis, like a strawberry cervix you can see in this picture, and a copious vaginal discharge that commonly is yellow-green and malodorous. The pH of this discharge is more than 4.5. Trichomoniasis, diagnosis and treatment. Diagnosis is confirmed by anamnestic data, objective examination, vaginal smears. The main principles of treatment are: first, treatment of the woman and her sexual partner avoiding intercourse until the patient and her partner are cured. Second, using of anti-trichomonads treatments with local treatment and gynetic procedure, shaving hair on pubis, everyday changing of underwear. And third, treatment accompanying disease of genital organs. Anti-trichomonad remedies are metronidazole, it also called trichopol, cleon, metrogel, flagyl, physigen, tinidazole, atrican, naxogen, tiberal, solcotrichovac, and tigenan. Recently, the treatment of trichomoniasis, metronidazole should be prescribed. On the first day, the woman used 0.25 grams 4 times a day. On the next days, 0.25 gram 3 times a day. All dosage of treatment course in 5 or 6 grams. Tinidazole is used in such regimen after meals once 2 grams or 4 tablets each, or 1.5 grams or 1.5 gram every 15 minutes 4 times, or 0.15 grams twice a day during 7 days. Naxogen is used in dose 500 milligrams twice a day, 6 days. During pregnancy and breastfeeding, all these medicine are forbidden. Cleon D is used in the form of vaginal tablets, 1 table for night during 10 days. Locally antiseptic solution can be used, Balis-2, or chlorhexidine or trichomonacid. And of course, control of the treatment is fulfilled during 2 or 3 menstrual cycles. Syphilis. Syphilis is an infective disease that is transmitted sexually. The pathogen is Treponem pallidum. In microscopic examination, it has spiral shape and is movable. Optional temperature for reproduction of Treponema is 37 degrees. It is very sensitive to different external conditions. It dies during boiling, drying, under the influence of different chemical agents, and 90% ethanol. Treponema pallidum dies in 24 hours outside of the body. The ways of transmission: sexual perversion, urogenital, homosexual contacts, transplantal, congenital syphilis, when a child is infected by transplacental transmission. Professional, while examining the ill person with wet surfaced rash. And transfusion, very rarely, is a sequel of blood transfusion from the ill person. Clinical manifestation of syphilis. There are 3 periods. First period is incubational period. It lasts 3 or 4 weeks. After finishing incubational period, the first signs appear only in the area of agent inoculation. This is so-called primary lesion, ulcered chancre. It appears as a painless indurated papula on skin or mucosa with erosion or necrosis of the surface. It is a hard-based, well-circumscribed lesion. There is no inflammation around it, and it has smooth surface with serous discharge. Its size is from several millimeters to a few centimeters, and it can be coated with whitish discharge like all fat. On mucous genital organs or anus, it is like fissure. Sometimes chancre can gangrenize. Indurative edema belongs to atypical form of chancres. Labia major enlarged in size and they're firm and painless. Chancre on pubis, thighs, or on cervix can occur rarely. In the chancre is situated of the genital organs, then after nearly 7 days, the inguinal lymphatic nodes enlarge on one side, sclerodenitis, pubo, rarely in both sides. They are firm, movable, painless, and they are not connected with skin and have no suppuration. First roseolus, little red macula, up to 1 centimeters in size, appear on body skin. It calls like a secondary syphilis. After 6 or up to 8 weeks of chancre development, the body temperature may rise and the night headache, bone pain. There is night headache and bone pain. Treponemas are appearing in the blood, so-called treponem sepsis, and disseminated rash on skin and mucosal layers. Here you can see syphilis, different periods. First period is prodromal without any manifestation, and primary syphilis with chancre. Here you can see a chancre on the labia, and secondary syphilis with rash, little rash here and on the arms and on the head. Diagnosis is presented by Wassermann reaction of treponem immobilization. Treatment. Treatment of syphilis is provided by penicillin antibiotics, betadine, retaprane, extensiline in venerological dispensary. Prophylaxis. First, avoiding of extramarital relationships. Use condom. And second, if coitus was without condom, it has to be torn, then, or it has been torn, then the external genital organs should be washed with soap and warm water and during the first 2 hours, and cleaning of genitals should be performed. Differential diagnosis of pelvic inflammatory disease includes ectopic pregnancy, acute appendicitis, endometriosis, irritable bowel syndrome, complications of an ovarian cyst, etc., rupture or torsion. Functional pain. Pain is unknown physical origin. In this picture, upper you can see left side salpingitis. Here you can see. Left fallopian tube is dilated more than 5 times than with comparison to intact right fallopian tube. Tubovarian abscess in the pelvic peritonitis are considered to be the main complications. Acute lower abdominal pain and fever are usually present. Right upper quadrant pain associated with perihepatitis, Fitzhugh-Curtis syndrome can occur, may be the dominant symptom. Here is the liver, you can see here, and these are adhesions. In pregnancy, PID during pregnancy has been associated with an increase in both maternal and fetal morbidity. Therefore, parenteral therapy is advised, although none of the suggested evidence-based scheme is not proved safety. There is insufficient data from clinical trial recommendations of specific scheme for pregnant women with PID, and empirical therapy with agents effective against gonorrhea, chlamydia, and anaerobic infection should be considered, taking into account local antibiotic sensitivity patterns, etc. Ceftriaxone 2 grams once daily plus erythromycin intravenous 50 milligrams per kilogram once daily, with the addition of metronidazole given orally 500 milligrams twice daily, per rectum 1 gram 3 times daily, or intravenous 500 milligrams 3 times daily. Diagnosis. Testing for gonorrhea, chlamydia, and Mycoplasma genitalium in the lower genital tract is recommended since the positive result supports the diagnosis of PID. However, the absence of infection from the endocervix or urethra does not include PID. The absence of endocervical or vaginal post cells has a good negative predictive value, 95%, for a diagnosis of PID, but their presence is not specific. Elevation of white cell count can occur in women with PID, but this is usually normal in mild cases. Laparoscopy may strongly support a diagnosis of PID, but is not justified routinely on the basis of associated morbidity, cost, and the potential difficulty in identifying mild intratubal inflammation or endometritis. Ultrasound scanning may be useful to confirm pelvic abscess. Computed tomography or magnetic resonance imaging can help to find out other causes of peritonitis. Endometrial biopsy may also be helpful when there is a diagnostic difficulty, but there is insufficient evidence to support its routine use. A pregnancy test should be performed to help exclude an ectopic pregnancy. Therapy. Broad-spectrum antibiotic therapy is required to cover Neisseria gonorrhea, Chlamydia trachomatis, and anaerobic infection. It is also desirable to include microbiological cover for all other possible pathogens: Mycoplasma genitalium, Streptococci, Staphylococcus, Escherichia coli, and Haemophilus influenza. The choice of an appropriate treatment regimen may be influenced by, first, local antimicrobial sensitivity patterns, local epidemiology of specific infection, patient preference and compliance, and severity of disease. Choice of treatment regimen should be influenced by the following. Mild and moderate cases should be treated as outpatient with oral therapy. Intravenous therapy, when given, should be continued until 24 hours after clinical improvement and then switched to oral. Dosage recommendations may need to be adjusted depending on local licensing regulation and the availability of drug formulation, etc. Metronidazole may be dosed at 400 or 500 milligrams. The optimal duration of treatment is not known. Most clinical trial reports a response up to 14 days of therapy. No difference of efficacy has been demonstrated between the recommended regimens. Information, explanation, and advice for patient. Patients should be advised to avoid unprotected intercourse until they and their partners have completed treatment and symptoms have resolved. A detailed explanation of their condition with particular emphasis on the long-term implications for the health themselves and their partners should be provided, reinforced with clear and accurate written information. Appropriate information should include: fertility is usually well preserved in women with first episode PID who receive prompt appropriate antimicrobial therapy. The risk of impaired infertility increases significantly with each subsequent episode of PID, approximately doubling with each new presentation. Risk of impaired fertility is increased in clinically more severe PID. Chronic pelvic pain of varying severity affects around 30% of women following PID. PID increases the relative risk of a subsequent pregnancy being an ectopic, but the absolute risk of ectopic pregnancy remains low at around 1%. Although laparoscopic division of hepatitis adhesion has been performed in women with perihepatitis, there is insufficient clinical trial evidence to make specific recommendations for treatment beyond antibiotic therapy. Follow-up: 72 hours review or control is recommended for those with a moderate or severe clinical features and should show a significant clinical improvement. The absence of effectiveness suggests further investigation, correction of parenteral therapy, and/or surgical intervention. The microbiology testing might be repeated in women who have positive reaction on gonorrhea, chlamydia, or Mycoplasma genitalium before treatment. In those with persistent symptoms, where antibiotic sensitivity are unknown or resistance is present, history of poor compliance with antibiotics, inadequate tracing of sexual contacts where there is a possibility of persisting or recurrent infection. Thank you for your attention.